Hello, I'm Professor Sims, and in this video I will discuss joints. This is the 7th in a series of 10 lessons held as part of my Anatomy and Physiology 1 course. If you are a student currently enrolled in this course, please consult the syllabus and course Moodle site for assignments, quizzes, due dates, and other course information. In this unit, we will learn about the function and structural classifications of body joints, the features of fibrous, cartilaginous, and synovial joints. We are going to talk about the different types of movement and discuss the structures and movements allowed by each joint, and we will see how the body joints are developed. The adult human body has 206 bones, and with the exception of the hyoid bone, each bone is connected to at least one other bone. Because the bones of the skeleton are relatively inflexible, movement can occur only at articulations, and those articulations are called joints. This is where two bones interconnect. Each joint reflects a compromise between the need for strength and the need for mobility, and as a result, articulations differ in the amount of movement permitted, and this is what is known as the range of motion. The anatomical structure of a joint determines the type and amount of movement that may occur at that joint. Joints are categorized based on whether adjacent bones are connected by fibrous tissue, cartilage, or a fluid-filled joint cavity. Fibrous joints are held together by fibrous connective tissue, but they don't have cartilage and they have no cavity between the bones. Fibrous joints are either synarthrotic or amphiarthrotic. Cartilaginous joints are held together by fibrous connective tissue, such as ligaments, but they also possess either hyaline cartilage or fibrocartilage. Cartilaginous joints lack a joint cavity and are either synarthrotic or amphiarthrotic. Synovial joints are held together by fibrous connective tissue, hyaline cartilage, or fibrocartilage, and they do possess the joint cavity. All synovial joints are diarthrotic. Synovial joints are quite complex in structure, and they're the most numerous type of joint in the body, and they permit the greatest range of motion. Immovable joints like sutures in the skull. These are shown in figure 9.2. These are the suture joints of an adult's human skull. Sutures are narrow joints between most skull bones, and they're a type of synarthrosis. So they're a synarthrotic joint. And they're also fibrous joints, and that is the classification because they connect to bones of the skull with fibrous tissue and because they're immobile. These sutures strongly unite adjacent skull bones, protect the brain, and form the face. Figure 9.3 illustrates how intervertebral discs connect adjacent vertebrae in the spinal column. This is an example of a joint that is structurally classified as cartilaginous because it's made up of fibrocartilage, and functionally classified as amphiarthrosis because it allows for limited mobility. Diarthrosis or diarthrotic joints are further categorized based on the degree of movement they allow. Uniaxial joints permit movement in one plane. Biaxial joints enable movement in two planes. And multiaxial joints allow movement in three planes. So an example of the uniaxial joint is your elbow. An example of the biaxial joint is the knuckles in your hands. And then multiaxial joints, and examples of those would be the shoulder and the hip. And we are going to look at these a lot more in just a minute. At a fibrous joint, the adjacent bones are directly connected to each other by fibrous connective tissue. And that means that the bones do not have a joint cavity between them, and the gap between the bones may be narrow, usually, but sometimes they can be wider. There are three types of fibrous joints. A suture is the narrow fibrous joint found between most bones of the skull. A syndesmosis joint, this is when bones are more widely separated, but they're held together by a narrow band of fibrous connective tissue called a ligament, or a wider sheet of connective tissue called an interosseous membrane. This type of fibrous joint is found between the shaft regions of the long bones in the forearm and in the leg. Gymphosis is the narrow fibrous joint between the roots of a tooth and the bony socket in the jaw into which the tooth fits. So as we've seen, sutures are a type of synarthrotic joint located only between the bones of the skull. Notice how the edges of the bones are interlocked and bound together at the suture by dense fibrous connective tissue. Let's take a moment to watch a clip that better illustrates this.
These joints are synarthroses, meaning they have no movement. The sutures seen on the skull's anterior include the frontonasal suture, frontozygomatic suture, zygomaticomaxillary suture, and intermaxillary suture. The frontonasal suture links the frontal and nasal bones. If you need a review of the bones of the skull, check out our videos, which are linked in the description. The frontozygomatic suture is found between the frontal bone and the zygomatic bone. The zygomaticomaxillary suture is between the zygomatic and maxilla bones. The intermaxillary suture articulates the two maxilla bones. In addition, children have a suture called the metopic or frontal suture, which runs through the frontal bone. This suture normally disappears by the age of 7, but in rare cases it can persist throughout a person's lifespan. Now we move on to the superior aspect of the skull, which has only one suture, the coronal suture, found between the frontal and parietal bones. Note also that this point, which is the convergence of the sagittal and coronal sutures, is called bregma. Now on to the posterior aspect of the skull. There are two sutures, the sagittal and lambdoid sutures. The sagittal suture is found between the parietal bones, while the lambdoid suture is found between the parietal and occipital bones. The point at which these sutures converge is known as lambda. Now let's look at the sutures on the skull's sides. Here we find 5 sutures: sphenofrontal, sphenoparietal, occipitomastoid, temporozygomatic, and squamous sutures. The sphenofrontal suture articulates the sphenoid and frontal bones. The sphenoparietal suture is between the sphenoid and parietal bones. The occipitomastoid suture connects the occipital bone and the temporal bone's mastoid process. The temporozygomatic suture links the temporal and zygomatic bones, and the squamous suture is between the parietal and temporal bones. Finally, let's check out the sutures on the skull's inferior aspect. There's the petrooccipital, sphenooccipital, median palatine, transverse palatine, and petrotympanic sutures. The petrooccipital suture connects the occipital bone and the petrous part of the temporal bone. The sphenooccipital suture is found between the sphenoid bone and the occipital bone. The median palatine suture runs between the horizontal plates of the palatine bones. The transverse palatine suture runs between the palatine process of the maxillary bone and the palatine bone. Finally, the petrotympanic suture is located between the temporal mandibular joint and the tympanic cavity.
During infancy, broader regions known as fontanelles offer flexibility in the skull, and this is shown in figure 9.6. These connections of fibrous tissue between the skull bones will gradually close after birth and become sutures. This phenomenon exists to facilitate skull growth and brain development in infants, as well as provide some flexibility so that the baby can be born vaginally without injury to her or her mother. Syndesmosis observed notably in the forearm and leg. This is where bones are separated, but they're held together by ligaments or interosseous membranes. While providing stability, they permit limited movement, classified as amphiarthrosis, and this type of joint is important for functions such as weight bearing and limb mobility. The most common example of a syndesmosis joint is the distal articulation between the tibia and fibula, which are shown here. This is called the tibiofibular joint, and it provides support for the legs and the ankles. So they're, again, weight-bearing joints. Gomphoses are synarthrotic, which are, again, immovable joints. And they're also known as peg and socket joints. And you will see these in the maxilla and mandible, where the teeth are anchored in the alveolar sockets. The periodontal ligament, which is a fibrous connective tissue, connects the tooth roots to the bony socket walls. And this ensures that they're structurally integral. At cartilaginous joints, adjacent bones are connected by cartilage, a flexible connective tissue. These joints lack a joint cavity and involve bones joined together by either hyaline cartilage or fibrocartilage. Cartilaginous joints can be subcategorized into synchodrosis or symphysis. A synchodrosis joint is a rigid, highly cartilaginous bridge that unites the bones of this type of joint. It can be temporary or it can be permanent. And an example of this cartilaginous joint found between the ends of the first pair of ribs and the manubrium of the sternum. symphysis. This is when bones are joined by fibrocartilage, and as we've discussed before, fibrocartilage is a very strong tissue and it's resistant to bending forces. So this kind of joint allows for limited movement and it's functionally classified as amphiarthrosis. Examples include the pubic symphysis and the intervertebral symphysis, which provide stability and cushioning between the adjacent bone. This is figure 9.7a, and this is showing the epiphyseal plate that is growing in a long bone. This here is another example of synchodrosis, and more specifically, this is a temporary synchodrosis where the bone lengthening is occurring. And then permanent synchodrosis, this is when, like in the thoracic cage, where it will retain the hyaline cartilage throughout the rest of its life. So you can have syncochondrosis that is happening as you're having growth, and then you can have syncochondrosis at the end of that growth that goes throughout the rest of your life. Figure 9.7b. This is showing the pubic symphysis, which is another example of the symphysis joint. So we saw that there is going to be a fibrocartilage pad that separates the two right and left hip bones. So you can see that here. This is what is known as the pubic symphysis. Now we're getting to the more interesting stuff, your synovial joints. These, again, are the most prevalent type of joint in the body. They feature a joint cavity, which is characteristically not seen in fibrous or cartilaginous joints. So the fluid-filled space between bones allows them to articulate smoothly without connection, and this greatly increases mobility. Synovial joints are defined as an articular capsule forming the joint cavity walls with articular cartilage covering bone surfaces to prevent friction. A synovial membrane secretes synovial fluid for lubrication, and lubrication is when part of an articular cartilage is compressed during movement. Some of the synovial fluid is squeezed out of the cartilage and into the space between the opposing surfaces. This thin layer of fluid reduces friction between the moving surfaces. Additional structures like articular discs, menisci, fat pads, bursae, and tendon sheaths further aid in joint function and protection. So now we're starting to see how synovial joints are a lot more complex than fibrous or cartilaginous joints. Figure 9.9 shows the accessory structures typical of a synovial joint. In this case, we're looking at the knee joint. Notice the different bursae. A bursae is a small fluid-filled pocket that forms in connective tissue. Each bursa contains synovial fluid and is lined by a synovial membrane. Bursa often formed where a tendon or ligament rubs against another tissue, and it's located around most synovial joints. This reduces friction and acts as a shock absorber. Also notice the fat pad. Fat pads are localized masses of adipose tissue covered by a layer of synovial membrane. Fat pads protect the articular cartilage and act as packing material for the joint. So when the bones move, the fat pads fill in the spaces created, and as the joint cavity changes shape, the fat pads kind of absorb that shock so you're not having pain in your joint. There are 6 types of synovial joints that you need to be familiar with. These are pivot, hinge, condyloid, saddle, plane, and ball and socket joints. Here is a clip that is going to go over those 6 types, and we'll talk about them some more in just a moment.
Synovial joints are the freely mobile joints in which the articulating surfaces have no direct contact with each other. Ball and socket, where the ball-shaped surface of one rounded bone fits into the cup-like depression of another bone. Permits free movement in numerous axes. For example, the hip joint. Condyloid contains a convex surface which articulates with a concave elliptical cavity. They are also known as ellipsoid joints. For example, metacarpal phalangeal joint, wrist joint. Gliding plane. The articular surfaces are relatively flat, allowing the bones to glide over one another. For example, a acromioclavicular joint, subtalar joint. Hinge. Permits movement in one place, usually flexion and extension. For example, elbow joint, knee joint. Pivot. Allows for rotation only. It is formed by a central bony pivot. For example, proximal and distal radio-ulnar joints. Saddle. named due to its resemblance to a saddle on a horse's back. It is characterized by opposing articular surfaces with a reciprocal concave-convex shape. For example, carpal-metacarpal joints.
So each subcategory of synovial joint is described based on the shape of the articulating surface of the bone that they connect to. So the ball and socket joint is where you have the spherical end of one bone that articulates with a cup-like socket of another bone. A condyloid joint is also known as an ellipsoid joint, and this is where you have an oval articular surface of one bone that goes into a complementary depression in another bone. An example of this is metacarpophalangeal joint, which is the first knuckle in your hand. Another example is the wrist. A plane joint is also known as a gliding joint, and this is where you have articular surfaces that are flat and only allow for short gliding movement. A hinge joint is where you have a cylindrical projection of one bone that fits into a trowel-shaped surface on another bone. Pivotal joint is where you have the rounded end of one bone that protrudes into a sleeve or a ring composed of a bone or ligament. Finally, a saddle joint is where you have an articulating surface that has a concave area that fits with a convex area on another bone. Figure 9.10 shows the different synovial joints categorized by their shapes and movements. The proximal radioulnar joint is an example of a pivot joint. Your elbow joint and your knee joint, these are example of hinge joints. The radiocarpal joint is an example of a condyloid joint. Your first carpometacarpal joint and your thumb, these are both examples of saddle joints. The sacroiliac joint is an example of a plane joint. So the sacroiliac joint can be seen here. It's the plane joint between the tarsal bones in your foot. And then the shoulder and hip joints are examples of ball and socket joints. Damage to the synovial joints can be very debilitating. For example, arthritis is a joint disease where synovial membranes thicken and fluid decreases, causing pain and friction in the joints. Surgery or artificial joints may be needed if the damage is too severe. Osteoarthritis, also known as degenerative joint disease, mainly affects people over 60 due to wear and tear or genetic factors. In the U.S., about 25% of women and 15% of men over 60 are affected. Rheumatoid arthritis is an autoimmune disease where it's more common in middle-aged adults and women, linked to infection, genes, and hormones, changes in your hormones. Gouty arthritis, also known as gout, results from excess uric acid forming crystals in the joints. And this causes sudden pain, stiffness, and swelling, usually in the big toe. It's more common in men, and its attacks may recur if untreated. Figure 9.11 shows how osteoarthritis of the hip joint causes erosion of articular cartilage, and this results in inflammation, stiffness, and pain in the hip joint. The structure of each synovial joint determines the movements that it can produce. So ball and socket joints have the greatest range of motion, but multiple joints often work together to achieve specific movements in different body regions. For example, flexion and extension involved forward or backward bending. This is in the neck, the trunk, the limbs, all within the sagittal plane. Abduction and adduction, this is the lateral limb movements within the coronal plane. Circumduction entails circular body region movements, while rotation involves twisting around an axle, observed in pivot and ball and socket joint. Supination and pronation, this is when you have your forearm rotation between the palms up and palms down positions. Dorsiflexion and plantar flexion, this is at the ankle joint, and it is an inversion and eversion involving foot angles. Protraction and retraction move the scapula or mandible exteriorly or posteriorly, while depression and elevation lower and raise them. Superior and inferior rotation pertains to scapula movements affecting upper limb abduction, and then opposition and reposition refers to thumb movements for grasping and releasing objects. We will go over all of these types of movements in more detail, but first please watch this clip.
Synovial joints come in 6 different configurations that together allow pretty much any movement your body can make, from a subtle head nod to a vigorous jumping jack, all of which you will find in action at your typical dance party. Seriously though, dance parties are an excellent place to study skeletal physiology. I mean, let's just take this from my perspective. I'm at my high school prom. I'm wearing a tux that is really uncomfortable, and I'm feeling kind of shy standing on the edge of the crowd. Maybe I want to test the waters out a little bit with a little hand dancing, just the hand going. Waving my hand from side to side. It's a type of gliding movement, one that occurs when one flat bone surface glides over another. All these motions use gliding or plane joints, like the one between the distal ends of your radius and ulna and the carpal bones of your wrist. But say after a while, I feel like these gliding movements just aren't enough to fully express myself. I have to enlist the more versatile angular movements. These are the types of motion that either increase or decrease the angle between 2 bones across any plane in the body, like if I bob my head or kick my leg up or raise the roof, if people still do that. If that bending motion decreases the angle of the joint and brings those bones together, like when I bend my arm together, that movement is called flexion. When I bend it back, I'm increasing that angle, and it's called extension. And if I continue that motion beyond my normal anatomical positioning, and it's somewhat dangerous, that is called hyperextension. These motions enlist the hinge joints. Similarly, my oval-shaped condylar knuckle joints allow my fingers to bend and ball up for a good fist pump. Now I'm getting super into it. I might raise my arms up over my head, while the act of raising my arms away from my body is called abduction, while moving them back down toward the body is called adduction. And this here lasso movement, that's circumduction, a combination of all 5 of those movements that allow the forearm to move in a circle while the elbow joint stays relatively stable. Which really makes you want to give credit to those cowboys. Now if you want to get really serious about that lassoing and expand it to include the entire arm, the move eventually will morph from an angular movement to a rotational one, a motion that turns the bone around its axis, in this case, the humerus. Hip and shoulder joints use a ball and socket design that allow rotational movement, but the more flexible a joint is, the more unstable and fragile it is, which is one reason why you see so many dislocated shoulders and hip replacements. And it's worth pointing out that some movements are just special and unique and weird and only occur in a few select joints, especially in your hands, feet, and jaw. For example, your ability to touch your thumb to your fingertips or give a thumbs up is thanks to opposition movement facilitated by your saddle joint, which makes your thumbs opposable. The pivot joint between your radius and ulna allow you to rotate your palm forward or anteriorly in a motion called supination, and turning it backward or posteriorly is called pronation.
Figure 9.12 illustrates flexion and extension, where we are in the sagittal plane of motion, and that's how the shoulder, hip, elbow, knee, wrist, metacarpophalangeal, metatarsophalangeal, and interphalangeal joints. This is how all of these move with flexion and extension. Anterior bending of the head or vertebral column is called flexion, and then posterior bending, any type of movement where you're bending posteriorly, this is called extension. Moving the limb or hand laterally, which is away from the body, or spreading the fingers or toes, this is abduction. Adduction brings the limb or hand towards or across the midline of the body, or when you bring your fingers and toes together. Circumduction is the movement of the limb, hand, or fingers in a circular pattern by a combination of flexion, adduction, extension, and abduction motions. Adduction, abduction, and circumduction take place at the shoulder, hip, wrist, metacarpophalangeal, and metatarsophalangeal joints. Turning your head side to side or twisting your body, this is rotation. Medial and lateral rotation of the upper limb at the shoulder or lower limb at the hip involves turning the anterior surface of the limb toward the midline of the body or away from the midline. Supination of the forearm turns the hand to the palm forward position in which the radius and ulna are parallel, while forearm pronation turns the hand to the palm backward position in which the radius crosses over the ulna to form an X. Dorsiflexion at the ankle joint moves the top of the foot towards the leg, while plantar flexion lifts the heel and points the toes. Eversion of the foot moves the sole of the foot away from the midline of the body, while foot inversion faces the sole inward towards the midline of the body. Protraction of the mandible pushes the chin forward, and retraction pulls the chin back. Depression of the mandible opens the mouth, while elevation closes it. Opposition of the thumb brings the tip of the thumb into contact with the tip of the fingers of the same hand, and reposition brings the thumb back next to the index finger. As we've seen, synovial joints are specialized to allow specific movements, with their ranges of motion shaped by structural type, ligaments, and muscle. And here's a few more examples. The atlantoaxial joint of the vertebral column is a pivot joint between the atlas and the axis. So this is the C1 and C2 vertebrae. And this enables head rotation from side to side. The temporomandibular joint, TMJ, you've heard of it. This is in the mandible, and it's a modified hinge joint that allows for jaw opening, closing, protrusion, retraction, and side-to-side movement. And this is the joint that's going to be most essential for chewing and speaking. Please watch this short animation that illustrates how the TMJ joint works and what would happen if it doesn't work the way that it should.
The temporomandibular joint, or TMJ, is where your lower jaw meets your skull. You have two temporomandibular joints, one in front of each ear. Each joint connects your lower jaw bone, called the mandible, to the temporal bones of your skull. A soft cushion, called a disc, sits between the bones. The rounded ends of the mandible and the discs slide forward when you open your mouth. They slide back in place as you close your mouth. Muscles are attached to the mandible and control its movement. The joint can open and close like a hinge. But, unlike many other joints, the TMJ can also slide forward and backward, and side to side. Because of this sliding ability, the joint needs your jaw muscles and teeth to help guide it into proper position when you open and close your mouth. In one type of TMJ disorder, your disc may move out of place. In a second type, your joint can be damaged by medical problems like arthritis, where your joint becomes inflamed and breaks down. And in a third type, you may have painful spasms in your jaw muscles. Other health problems, such as grinding your teeth at night, can also cause symptoms in the joint. The most common symptom of TMJ disorders is pain in the joint and nearby muscles. Sometimes pain in the TMJ is mistaken for an earache because the ear is so close to the joint. Headaches can result from pain that starts in the muscles around your jaw and temple area. Other symptoms include problems moving your jaw, painful clicking when you open or close your mouth, and changes in the way your teeth meet.
The glenohumeral joint, also known as the shoulder joint, is a ball and socket joint connecting the humerus and scapula. And this joint allows for extensive mobility in all directions, but depends largely on the rotator cuff muscles for stability due to its minimal ligamentous support. The elbow joint, that's a hinge joint formed by the humerus, radius, and ulna, permitting flexion and extension, with some rotational stability at the proximal radio-ulnar joint for forearm pronation and supination. The hip joint is another ball and socket joint joining the femur and acetabulum of the pelvis. It provides a wide range of motion, but is more stable than the shoulder due to strong surrounding ligaments and a deep socket supporting the weight-bearing activities. The knee joint is a complex hinge joint involving the femur, tibia, and patella, and it allows for flexion, extension, and slight rotation. It includes ligaments like the ACL and PCL and menisci that stabilize the joint but also make it vulnerable to injuries. Figure 9.20 shows how a strong blow to the lateral side of an extended knee can cause tearing of the tibial collateral ligament, damage to the medial meniscus, and rupture of the anterior cruciate ligament. So when you hear that someone has had a torn ACL, it's this ligament here, right in the middle of this synovial joint in the knee. Finally, we have the ankle joint, also known as the talocrural joint. It's a uniaxial hinge joint that allows only dorsiflexion and plantar flexion of the foot. Movements at the subtalar joints between the talus and calcaneus, along with other intertarsal joints, allow the foot to move in eversion and inversion. Ligaments connecting the medial and lateral malleus to the talus and calcaneus help support the ankle and prevent excessive eversion and inversion. Here is another video that goes into some more depth about the anatomy of the ankle joint.
So the ankle joint is this joint here, between the talus, the tibia, and the fibula. So it's a synovial hinge joint, and the main movements that you get at this joint are dorsiflexion and plantarflexion. So one way of remembering which way is plantarflexion and dorsiflexion is, if you just think of a plant on the floor and you want to squash that plant, you will press down in this direction. So plantarflexion is squashing a plant movement, and dorsiflexion is bringing the toes up towards the head. So the distal ends of the fibula and the tibia essentially form this socket which the talus slots into. So on either side of the talus you've got the malleoli, so you've got the lateral malleolus of the fibula laterally, forming the lateral wall of this socket. Medially you've got the medial malleolus of the tibia, forming the medial wall of the socket. And superiorly the roof of the socket is formed by the inferior surface of the tibia. So I've just isolated these two bones, the tibia and the fibula, and you can see the roof of the socket formed by the inferior surface of the tibia bone, and then you've got the medial malleolus and the lateral malleolus forming the walls of this socket. So the talus just slots into this socket formed by these two bones. So we'll just take a quick look at some of the features of the distal tibia and fibula and the talus before going on to talk about the ligaments of this joint. So I've pointed out the lateral malleolus of the fibula and the medial malleolus of the tibia, and there's some ligaments which bind these two bones together at the distal end. So this is the anterior tibiofibular ligament, and this one posterior is the posterior tibiofibular ligament. So the bones are also held together by the interosseous membrane as well, so this interosseous membrane is supported distally by these two ligaments. So if I just rotate around to the back, you can see there's a groove on the back of the tibia on the medial surface. So this is a groove for the tendon of the tibialis posterior muscle. So you can see this muscle over here running behind that groove. And then laterally, you've got the malleolar fossa on the medial surface of the lateral malleolus, and you've also got a groove for the fibularis longus muscle. So you can see this muscle running behind that groove, or in that groove rather. So we'll just take a quick look at the talus bone as well. So the talus bone obviously articulates above with the tibia and the fibula. Below it articulates with the calcaneus, and anteriorly it articulates with the navicular. So I've just isolated this bone, and we're looking at it medially here. So it's got a head anteriorly, a neck, and a body. So the body is, so I've rotated around, this is anterior now, up here. So you can see the body is slightly wider anteriorly. So this means that when the foot is dorsiflexed, the wider anterior part kind of gets wedged between the two malleoli. So the ankle joint is actually stabler in dorsiflexion. So let's take a look at the inferior surface. There's various facets on the inferior surface which articulate with the calcaneus, but we don't need to worry about that in this tutorial. The superior surface, you can see this kind of, it's dome-shaped, so it's kind of cylindrical, and this slots into that socket I showed you before. So the upper surface articulates with the inferior surface of the tibia, and this is called the trochlear surface. And then you've got the lateral surface, which articulates with the lateral malleolus, and you've got the medial surface, which articulates with the medial malleolus. So the joint capsule of the ankle joint consists of a fibrous and synovial membrane. So the synovial membrane attaches to the margins of these articular surfaces, and it contains the articular cavity, and the fibrous membrane covers over the synovial membrane. So, as with any hinge joint, you've got ligaments which line either side of the joint, so collateral ligaments, and the joint is fairly weak at the front and the back, but it's got strong ligaments either side. So medially, you've got the medial deltoid ligament, and laterally, you've got three separate lateral ligaments. So the lateral ligaments, you've got two ligaments connecting the fibula to the talus, so you've got one at the front and one posteriorly. And these are called the talofibular ligaments. So anteriorly, you've got the anterior talofibular ligament, and posteriorly, you've got the posterior talofibular ligament. And then you've got this ligament which connects the medial malleolus inferiorly to the calcaneus. So this ligament is called the calcaneofibular ligament. So those are the 3 lateral ligaments, and I'll just rotate the model medially so we can take a look at the medial complex of ligaments. So the medial ligaments are called the deltoid ligaments because they're a complex of ligaments which are triangular in shape. And this complex of ligaments consists of 4 separate ligaments. So the triangular shape isn't really shown that well here, but if you imagine that these 4 ligaments that we're looking at here are sort of blended together, and at the apex they attach to the medial malleolus, and they sort of form this kind of triangular shape which attaches to the navicular, calcaneus, and parts of the talus. So it's this triangular shape of ligaments that are blended together. So you've got 4 parts to this ligament. You've got 2 ligaments which attach from the tibia to the talus. So you've got an anterior and posterior tibio-talar part. And then you've got ligaments which attach to the navicular anteriorly and to the calcaneus inferiorly. So you've got a tibio-navicular part and a tibio-calcaneal part. So I've just switched over to a diagram which shows more clearly the actual triangular shape of this ligament when they're kind of blended together. So it's the medial deltoid ligament consists of 4 parts. And the word deltoid, you might remember it from the shoulder muscle, the deltoid muscle. It basically comes from the Greek delta, which is a triangular symbol. So that's why it's called the deltoid ligament. So that's the ankle joint.
During embryonic development, joints form alongside bones, guided by mesenchyme, which is the tissue that gives rise to bone, cartilage, and connective tissue. Mesenchyme gathers where future bones will form. In the skull, flat bones develop through intermembranous ossification, while the base and facial bones form through endochondral ossification. Here, mesenchyme becomes hyaline cartilage, creating a model for bone. Fibrous tissue fills the gaps between the developing skull bones, forming fontanelles, which we have seen later close to become suture joints in the skull. By week 4 of development, limb buds appear on the embryo's sides. Inside, mesenchyme transforms into hyaline cartilage, and synovial joints begin to form at the joint interzone. As cells in the center of this zone die, they create the joint cavity, while surrounding cells form the joint capsule and ligaments. Around week 12 of development, endochondral ossification begins, turning cartilage into bone. Hyaline cartilage remains at the epiphyseal plate, supporting bone growth through childhood, and as articular cartilage, it covers and cushions joint surfaces.
During embryonic development, cells called chondroblasts begin secreting cartilage that develops in the shape of the skeleton's long bones. The bluish, transparent avascular tissue formed is called hyaline cartilage. As the cartilage grows, the chondroblasts in the interior calcify and die. Blood vessels penetrate the structure and deliver osteoblasts. These cells lay down bone material. As the cartilage ossifies and spongy bone forms, a medullary cavity develops. At the ends of a long bone, ossification from cartilage also occurs. This process, in which hyaline cartilage becomes bone and grows, is called endochondral ossification. Bone growth continues through childhood. After puberty, bone tissue replaces the remaining hyaline cartilage, and the shaft reaches its adult length.
This is going to conclude the material for Chapter 9. I want to thank you guys, as usual, for watching. Don't forget to do the reading. Check the description for more videos related to these topics, and leave your questions for me in the comments below.